Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hi, everybody. Welcome to the Cracking Cancer podcast. I am your host, Dr. Kyle Concannon. I'm a physician scientist here at the University of Colorado. And here I am joined by Ross Camidge.
Hello, I'm Ross Camidge. I am the director of the lung cancer program here at the University of Colorado, and technically I'm Kyle's boss.
And in addition to being my boss, we're having you on today to talk about what it's like being a medical oncologist who yourself was diagnosed with a cancer, because I think you offer a unique perspective about some of the challenges in the cancer community, some of the things you've worked toward in terms of research, in terms of how the clinic has progressed, and then you're the recipient of the care that you've spent the last several decades really championing. So I'm interested to hear your thoughts about where things stand, how things could be better.
Well, let's address the ironic elephant in the room. So I'm a lung cancer expert, and I got diagnosed with stage 4 metastatic, incurable, use whatever term you like, lung cancer 3.5 years ago.
Yeah. What happened? Tell me more about what that was.
Well, it's funny because you have to tell this story so many times.
Yeah, sure.
And it's, but 3.5 years ago, which was, spring of 2022, I had a relatively short period of time with symptoms. I had a sort of pulled muscle, it felt like, or just tightness in my left shoulder, which I just assumed was getting old and, the gym damages you. And then I was stretching it and doing everything else, and I didn't put two and two together until sometime in May, when I developed an audible noise when I was breathing out, which it's not a wheeze. It was a funny thing where you would breathe out and then the pause, and then it's like you had a little accessory bit of your lung that then went whoo and breathed out a little bit more. And presumably there was a bit that was blocked, and that just built up the pressure, and there was a sort of bottleneck, and then it came out. And I couldn't explain that in any rational way. I wanted it to be late onset asthma and something like that, and I stole my wife's inhaler and, tried to see if it made a difference. But I had that literally for about 2 weeks. And then I went to see my primary care physician, and I said, as he was saying, well, let's give you a proper inhaler and see if it makes a difference. And I said, but I am a thoracic oncologist, can I have a chest x-ray? And he said, yeah, get one on your way out. So, I work in a hospital. So I leave his office, go down in the elevator, get my chest x-ray. It's like a walk through, come back to my office, and he phones me. And he says, there's something on the chest x-ray. At which point I'm bringing up the image of myself on my computer, and it's lung cancer. It's obviously lung cancer. There's something at the top of my right lung. Even though it's not in the report, I can see deposits in the other lung, and I can start to see what look like some nibble marks into the bones, which is probably why I had that painful shoulder. And that was on a Friday morning. Friday afternoon, I got a CT scan, which sort of confirmed everything. I think on Saturday or Sunday, I got an MRI of my brain, which showed a 2 centimeter, which in your brain is quite a large size, deposit just at the top of my brain stem. Mm-hmm. And as I was looking at it, I was going, that's not compatible with life. That's not a good thing. Because disease in your brain stem presents with being dead.
It can.
So it was like, clearly I'm not using most of my brain stem. And I think on Monday, I had a bronchoscopy. Tuesday morning, I had a PET scan. Tuesday afternoon, they got the molecular results of the biopsy back. I had a specific mutation, an EGFR mutation in my cancer. Mm-hmm. And the pill, which I would have started on, by chance, the husband of one of my patients who had passed on had given me her old pills back, and they were sitting on my desk. Sometimes we use them to start other patients on, a little bit ahead of time if their insurance is taking some time. Mm-hmm. And so I started the pills Tuesday evening. 4 days. From
diagnosis to treatment, that's fast pass.
Yeah.
But you also, you're in a position where you know more about this disease than most people, most oncologists, certainly more than most patients. So I'm curious, in that beginning, how did the knowledge that you have influence your reception of the diagnosis?
So there's two bits. So there's a professional bit, which, how long have you been a doctor now?
About 10 years.
Yeah. So I had that plus about, 20 odd years experience of being an oncologist. And so, professionalism kicks in. We're all trained in that sort of way. You see something, you do this, there's a differential between this, and you have to do this to figure it out. So that was going on, and you could focus your mind on that. But then a sort of personal bit kicks in. Mm-hmm. And that was usually after you'd gone through your checklist of things that you had to do. And that, you go through that bit where you suddenly go, oh my goodness, this is real. This is actually happening. This isn't just some act that I'm going through. And, I would sit on the stoop of our house with my wife during those first few days, because we have 2 teenage daughters and we hadn't told them initially. And we'd cry because, I know what it means. I know what the prognosis is. I know it's not good. And I had lots of bad features. I had deposits in my brain. I had certain additional mutations. I had a particular appearance down the microscope. All of these things were kind of like, I can't spin this as likely to be, the one who's going to do really well. You always hope that, but I couldn't spin that. And so I would cry mostly about two things. So one is I had to tell people, in my own team who are also my friends, that this was going on. Some of them were just incredibly nice. And these are people that you've had a professional relationship with, but you haven't necessarily had a personal relationship with. But like the radiologist phoned me up personally to tell me the result of, the brain MRI and the CT scan. And these are people who live in darkened rooms who never actually have any interaction with patients. And so I know it's very uncomfortable for them, and it was just incredibly touching. And then the other thing was any thought of my children.
Yeah.
You've just had your daughter.
The thought has occurred to me personally, and I don't have a terminal diagnosis, but the planning, actually, it's interesting you bring that up. One of the things I was telling one of my other friends was, one of the benefits of this podcast is if I were to be in a car accident today, my child would get to know me.
Yeah.
Like that's totally crossed my mind.
Yeah.
So I can't, sit in your shoes, but I understand why the mind goes there.
Yeah. And so, I don't know about you. So you're in early days of this, and you don't plan out your children's lives, and yet maybe you do, but good luck with that.
Some of that.
But some of it is kind of like, they're going to hit challenges in their life. Yeah. And it's the idea that you're not going to be there to do something to help. Yeah. And that would turn me into a big soggy wreck.
I can completely understand that. And, for you, that diagnosis now was quite a few years ago.
Yeah.
Has the coping, over time, does it get easier? Has it gotten easier?
Well, yes and no. When you start, you live as long as the next scan. That can be, the death knell that the cancer has progressed, it's going to be really bad, that you're going to be one of those early points on the curve who, the odds are all against you. So you get a little bit used to the anxiety associated with scans, but it's still there, it's still real. Mm-hmm. And you do sort of get your head around it. But yeah, if you really want to make me cry, we can talk about, my daughters again at some point.
Maybe we can save that one for another episode.
That would be awesome.
Yeah, a full hour of the two of us crying. There actually probably are people who would like to see that. We'll put that one behind a paywall.
It is sad. We're all human, and we all have these kind of little triggers inside us. And I can be totally professional, can totally fine, and then I can just start talking about it. I was talking to someone yesterday about their relation. This is an adult woman with their relationship with their father, who's in their 70s, and And she was sort of struggling to connect with him. And I was saying things like, well, just let him be a dad. And just saying those words out loud, even though it's somebody else and somebody else's daughter-father relationship, sort of made me tear up.
Just the memory of that relationship.
Yeah.
Well, and so you're mentioning how this experience has influenced you in your dynamics with other people. I'm curious how it's influenced you in your relationship with your patients. Is there something where having the malignancy itself has influenced how you care for other people in your own clinic? Because you're still practicing.
Yeah. Well, we should point out that I didn't go public with my diagnosis for 3 years. So my immediate family knew, close friends knew, and the immediate team that looks after me knew. But even within the team, like I wasn't having surgery, so I didn't tell the surgeons. The radiation oncologist knew. And within about a week of the diagnosis, we both told our children, because we wanted to be able to tell them that there was a plan. Daddy's got the kind of cancer that he looks after. You've seen how his patients do. Some of them do really well, and he's on treatment. And it's not a cure. We didn't sugarcoat it, but, he's on treatment and he's doing fine. And then for the people that knew, I asked them to keep the secret, to keep the circle of trust, for a number of reasons. One was I didn't want my own patients to panic. I mean, I was still fully functional. I wasn't on painkillers. I was thinking clearly. I did ask my team to say, if you think I'm behaving differently in the clinic, can you rat me out? Yeah. Like, it doesn't matter about loyalty. The priorities to the patients. And so far they haven't. But I don't want to be that doctor that people talk about behind their backs.
Yeah, no, I understand.
We don't want to see Dr. Concan.
I'm already that person.
Yeah, exactly. Is there anyone else available? That sort of thing. So there was that. There was an element of, we all make income by seeing patients, but we also make income by doing other things, consulting. And I wasn't sure if a diagnosis of lung cancer would just make that disappear. And we were rebuilding a house at the time, and so there's a lot of money going out, and so I didn't want to compromise money coming in. And there was a little bit, not so much, but a little bit of wanting to protect my daughters too. Yeah. That, kids can be cruel at school. Oh, I saw something about your dad having cancer. So it was just easier to keep it on the lowdown.
Sure. Well, it's interesting you mentioned the concern about how a lung cancer diagnosis being public will affect your income earning potential, your employment, because that's something a lot of patients have echoed to me. I'm sure people have echoed to you, is if my employer knows, are they gonna, what are they gonna do? So it's interesting to hear that concern, even from the thoracic oncologist who has the exact disease that you're.
Yeah, well, when we recruited you, I didn't tell you the diagnosis. Now, if I had told you the diagnosis when we were taking you out to dinner and schmoozing you, how would you have reacted?
Yeah, I don't think it would have negatively influenced my assessment of the position. I think it would have maybe framed the types of mentorship that I seek. Because you're one of my mentors and I go to you for questions. So I think it might have framed things a little bit differently in that regard. Not only from a patient care delivery element, because I think I want to get into it a little later about, how that's changed how you treat patients. Are you more aggressive? Are you less aggressive? Those kinds of things. But also just interpersonally, I think those kinds of things make someone more introspective. And that's a big thing we do on this podcast, is it's a time to talk to, Samantha and Ashley and JJ and the folks about these questions, these deeper questions. And so I think it might have, maybe you could say, positively framed just the knowledge of how to pursue the relationship, but that's something you would. It changes the dynamic of the relationship in a way that you'd need to want that. Yeah. Because someone can't unknow that.
Well, do you remember how I told you? Although I think you'd already heard rumors.
I heard rumors, but it wasn't a clear thing. We were in your office.
Yeah, like you hadn't really started. You were just kind of like setting things up. Mm-hmm. And I wanted to be the one to tell you. And I think, I established a way of breaking this particular news, which is, because I'd had to do it to a few people before then. Yeah. I think I said something along the lines of, we have, lots of patients, some of whom are well known, some of whom are secret about their diagnosis. And I need to tell you that one of our faculty members has actually got a diagnosis of lung cancer. And then I pause for dramatic effect, and then they go, and it's me.
That is exactly what happened.
Yeah, well, exactly.
To the beat. That's exactly.
I had showman to the end, but and yeah, you were awesome about it. You were like, yeah, shrug. No,
I mean, we're all.
What else do you want to talk about?
Yeah. Well, it's a vulnerable position to be in to talk about it, but it's also, from what I know of you, you're someone who's very objective. You want to get on with positive change. You're not someone who I think, at least to me, has sought my sympathy. I didn't get the sense that was the objective of the conversation. If it was that I have this and I'm struggling, that conversation would have gone very differently.
Yeah.
But you approached it in a very objective way, and we're both here to fight cancer, and to me this is another kindling of the fire to help us motivate to get after it. So yeah, I view it as a challenge more than.
I have never done played the cancer card for sympathy, apart from once. On a hike with my oldest teenage daughter who was dragging, and I went, well, I've got stage 4 cancer, and you can't even keep up with me, which went down terribly. I'd like to put it out. I'd like to regret that. That is the only time I have ever played that card.
It's a reasonable trump card.
Yeah.
Although Samantha Morell, our co-host who has HER2-driven lung cancer, she just had a lung resection, and she's hiking mountains, a week later. So
wow, that's good.
She's ridiculous. So the limitation of someone with stage 4 lung cancer is, like, if your benchmark is Samantha or you, people can do pretty well.
Come back to your question. Okay, yeah. So in the clinic for the first 3 years, remember, the patients didn't know. That's where we had this kind of segue. So the only person, so there was no prompt from them. We can talk about what that was like when they did know. I often get asked, did it change my practice? And my initial reaction was to point out that I didn't think I was a terrible doctor beforehand. And it's not like I went, oh my goodness, now I have this huge insight. But there, it does affect you. And I think probably some of the things I became more aware of was the kind of existential fear that all of the patients have of, worry about what the scans do or don't show, what delay does or doesn't mean, and sort of, giving them a pause to first of all let me bear witness to that, and secondly allow them to expand on that if they want to. I think that's helped. Sure, I can tell them what the inside of a CT scanner sounds like, and how claustrophobic an MRI is, and what chemotherapy tastes like when they stick it in your veins and you get the taste of the back of your mouth. But most of it, that human experience of recognizing what it's like and the anxiety associated with scans. Sometimes, if there's your partner in the room, help bridge that gap of understanding if it's there.
Has that manifested in a particular way? Like, do your conversations change, or?
I think I think probably like you, that you pay attention to the patient in the room and their body language and everything else, because not everything is immediately said out front. Doctors are scary, but trying to see if there is something that you want to bring out or give someone the opportunity to voice in the clinic. And, some things, all you have to do is go, yeah, it is scary. And that's all you need to do, just acknowledge it. But yeah, I think that's probably how I've changed the most.
One thing I've been curious about is patients will frequently phrase a treatment plan's decision around, what would you do if it were you? What would you do if it were a loved one? And I'm curious if you think, knowing what you know now, having been through what you've been through, can we answer that? I'm biased in that I think I know what I'm recommending, and at the time I think it's the best plan. but it's decoupled from the emotional urgency of having it yourself. So you get to see things in a particular way that you may not see them that way if it were you that had it. And I think this has played out even in patients we've mutually cared for in different contexts, where when people sometimes have more control and more influence, they'll do more things. And there's a push now. A lot of patients are doing more and more things.
Yeah.
And if it were me, I would probably be doing those things too. I can't guarantee it would be a better plan, but I'm curious if, when someone says, "What would you do if it were you?" knowing what you know now, do you think we're capable of answering that?
To some extent. So I think I've always tried to practice in a one-tier system. What I would recommend for myself or a loved one isn't any different from how I would treat a patient. And although I went, from symptom to treatment in 4 days, I didn't personally call in any favors. I suspect the team, did a lot of this themselves. But my experience of that was not lead by exception to say, oh, yeah, this is awesome. Sucks to be you to everyone else. But you lead by example and you say, look, well, if I can go through this in 4 days, why can't everybody? And I think by being someone looked after by your own team, I'm hopeful that that is some of the message that goes through, that they will treat every patient as carefully as they treat me. And I think they will. I think they're good people.
Well, and that speaks to I'd say the time delay. But in terms of how aggressive one would be, when you're the person with the cancer, I imagine it's pretty hard to pause and say not do more. When you have many options and you're in data-free zones of, is adding this going to help? Should we do more scans? Blood test? There's a lot one could do. Do you find that dynamic has changed?
So I think some of the things we did. So I started on a pill, and then I deepened the benefit by adding in chemotherapy early, getting it as a bridge to then zap everything with radiotherapy, so-called consolidation radiotherapy. That's not any different from what I've been doing in my own patients for several years. We helped to develop some of those treatments together with MD Anderson, and that's what I recommend for my own patients. Again, it's not, if you start to have a two-tier system, then there's something wrong.
Yeah, it's interesting you mentioned that. And for people who don't know, what you're mentioning and what you did as a treatment plan is approved standard of care. This isn't secret pills or secret chemos that we have access to that other people don't. What you did is a very normal and I would say average care plan.
Well, I think it's normal. I think it's accepted. How well it's routinely used outside of the ivory towers may be debatable. I think part of being in an academic center is to lead. One would hope that you lead by example.
I appreciate that you voiced what you went through, the treatment plan, but I do think there's a perception that we have this bucket of things for patients, and then we go to this other place, the good stuff for when someone we care about. And I think that's the origin of this phrasing. What would you do if it were you? What would you do if it were your family member?
Yeah.
And if it seems like we're being honest, then they're like, okay, you're giving us the real treatment, because this is a black box to everybody. I mean, It's complicated and we're in it. And then people go around to different institutions and they see these different recommendations, and there's no guarantee that one thing's better than the other. So I see where the mistrust comes from.
Yeah, I guess so. I've had only a single patient who said, "So are you on the good stuff then?" But he said it with a little bit of a smile on his face, but only a little bit of a smile. But no, we don't have a secret stash. And I think that understanding that oncologists tend to be more aggressive up front because they're afraid of what happens later, I think that has become a zeitgeist for everyone with cancer. It's gone from I would do me or my loved ones and everyone else can get, sloppy seconds, to No, we lead by example.
So I'm curious, you've experienced now 3 years of your own cancer care. What have the biggest limitations been, the biggest challenges in receiving care yourself?
I have had most of the complications that you can write about. I've had pulmonary emboli, I've had pneumonitis. I think frustrating things are the same frustrations that everyone gets, which is like, I need an MRI scan, and they said, we can fit you in 6 weeks' time. And they said, or you can drive 60 miles and you can have one tomorrow. So I got up at 5 in the morning and drove 60 miles to northern Colorado and had an MRI and then drove all the way back again. And that's frustrating, but it's the reality of, even in the richest country on earth is, we still have some resource limitations.
I mean, are they resource limitations, or are they how the resources are allocated? We're in
how's
Denver.
that different?
But we're in Denver right now.
Yeah.
There are many healthcare institutions here. There are tons of MRI scanners, but you have to drive 60 miles to use that one, for example. And I think there are people who see. We've been in the field for a long time, and we see these barriers that have been created. But I think there are people who are not in this system, and it's not very clear to them why they can't just go down the road and use their MRI scanner.
Do you know, that didn't even occur to me, but you're right. I guess what happens is you phone up the scheduler in your hospital who says, we can't fit you in, but let me look at the other places I can look at. Who are the ones in the same health system?
Right.
They're not looking at the competitor on the other side of the street.
And for the person who isn't aware of this system, I think to say, why can't I just go literally, 2 blocks over to a different hospital and use theirs? I don't have a good explanation other than your insurance, like the way this system is set up. I think I struggle with sometimes because.
Yeah. Well, the other thing that, of course, we struggle with in a multi-healthcare system such as the one we live in is that I can go get that MRI, but how does the information get back to my doctors here? I can get a report, but they may not necessarily have the prior scans to compare it to, or getting the images, might take a week or so to get over here and get uploaded, and then it doesn't get reported again by our people because they're going to go, well, no one's paying us for that.
Right. Well, and you mentioned the scans being delivered to the healthcare team.
Yeah.
And now the reports get directly to the patients, which is feedback I get all the time, that I got this directly to me, I didn't know how to interpret it, and usually it's at the diagnosis of a cancer, as people get a scan that says highly concerning for malignancy, and that's how they learn, like you did. You picked up.
I looked at my own scans, but yes.
But the report was there. What was it?
Well, no. I looked at all of the images before they were reported.
I guess it's still directly to you in one way or another.
It is. Cuts out the middleman.
Yeah, but I'm curious, do you feel for you, with the knowledge you have and your ability to look at small changes, I mean, you actually get to look at your own scans.
Yeah.
And you get to dwell over small nothings that in another patient you would say, this is scan-to-scan variation. But when it's you, I'm curious, how has that ability to look at your own scans affected your mental health, your decision making?
I'm laughing at the word mental health because it's like, oh, did we go crazy with it? I don't think so. Again, professionalism kicks in. And again, I do not believe I review my scans any differently than I review my patient scans. I think the key thing, which, I hope we all practice, is radiologist's report is a guide. It's not the eye of God. And so oncologists should actually learn to look at their own scans. And if they don't know how to, go speak to the radiologist and they can teach you how to look at them. Radiologists are human. They can miss out the scan they're supposed to compare it to. They can get their left and their right confused. They can just overcall stuff because they don't know they didn't know you had radiation last week or something. No one told them that.
Yeah, and this is something we had a episode with Lauren Groner, who does a lot of lung cancer screening work. She's a thoracic radiologist, and the humanization for the radiology group, I think they have a tough go of it. because they have to be read 100% of the time, and they're humans like everyone else. So.
And they get their butt sued all the time.
They do. Yeah, and you always have the retrospectoscope to look and say, oh, actually 3 years ago, that was the beginning of something, but they didn't mention it because you have so much stuff normally in the body. So yeah, I mean, I'm happy to hear that hasn't driven you crazy. I think it'd drive me crazy.
No, it's just normal. I go get a scan, I go up to my office and I look at it, and then so one of the questions you should ask me is, when you're the head of the lung cancer program and you get lung cancer, who looks after your care? And no, it sounds like I'm driving my own care. I'm not, but I'm not devaluing my own experience either. So my doctor is Tejas Patil, who I trained. He's an awesome guy. He's kind of slightly zen, and lets me kind of expound on what I think, and then he comes in with his thoughts too, and that's worked really well. He describes himself as my coach more than my oncologist, but he's really my oncologist.
I feel like that kind of verbiage is what our generation tends to use, is things that are more guiding and more patient-centered verbiage, I suppose, which with you makes a lot of sense.
Yeah, well, I mean, I think the easiest thing with Tejas is, we don't have a knowledge gap, whereas often with a physician and a patient, there's an inherent knowledge gap. And that you do everything you can to level that playing field, but usually there's always a knowledge gap. Although I've looked after a gazillion physicians as patients too, and sometimes they have a knowledge gap and sometimes they don't.
Well, and one thing I've realized more and more recently is that patients will minimize that knowledge gap themselves. Mm-hmm. And that's part of the objectives of this podcast and many of our other episodes, is help bring the floor up.
Yeah.
People bring studies. I had a patient the other day here's this clinical trial from this place. They're using this novel thing. I wasn't aware of that trial, so I look it up. And I think I strongly encourage that, because I think people do get better care when they're able to advocate for themselves from a thoughtful place, and it's not coming just from the anxiety. It's coming from a foundation that they've given themselves, because you were already an expert in EGFR-driven lung cancer, but I can tell you, Samantha, who has HER2-driven lung cancer, is now an expert in HER2-driven lung cancer. Yeah. She knows all the trials. She knows what the data is. You can be an expert in your disease. I think certainly.
I don't think it takes. I mean, don't want to negate all of the training that we've gone through, but it doesn't take that long to get up to speed.
Kind of to negate all the training we've been through.
No, seriously. The big secret is it's not that difficult.
Yeah, I mean, for a couple of months of keeping up to date and looking at some of the primary data, you'll have to Google a lot of terms, but yeah, I think you get there much faster than people think. Yeah. I think a lot of patients come into the office and they say, well, I'm not a doctor, but it's like, well, but you have the thing, and you've had it for a year or two now. You know a lot.
Especially if you have a specific subtype which you Google and you research and you join a patient advocacy group. Yeah. You might know more than a general oncologist who's looking after you. No, who's trying to stay up to speed with everything.
Well, even some of the specialists, because they get to know of something that's coming out of China that I'm not aware of. Yeah. So I think it's great that the field's going in that way, but with that comes all I would say the intellectual burdens of knowing all these things and all these things you could take action on, which I imagine you have too. The should I have, I imagine, is strong.
Well, yeah, I mean, I still think that there are things which are complete nonsense and you can tell they're nonsense very quickly. I mean, that's what experience teaches you. There's stuff which is like, maybe keep an eye on that. And I think one of the most informative things is like, okay, so if you have to travel to the other side of the world, how much data do you need to justify that time and expense versus if it was on the other side of the street?
Yeah. That's a tough thing to reconcile. Yeah. How promising is this new thing when you don't know?
I'll give you an example from the history books. Okay, so when We first developed treatment for ALK-positive lung cancer with crizotinib. First data came out in 2009, first time it was ever presented. In, I think, 2010, myself and a guy called Jack West, who was a prominent oncologist in Seattle and was very into social media, wrote an article that was called Have Mutation Will Travel. And it essentially said, the game has changed. Previously, people were like, well, I'm going to go and travel to MD Anderson, halfway across the country to go on something that may or may not work and probably has about a 5% chance of doing anything. Suddenly, when we could do a test on someone's cancer, say, this is actually the treatment that has an 80% chance of working, the reason to travel to go on something that has been much more personalized to you, the game was totally different.
I think it's an apt example because you also have an oncogenic mutation like ALK when that first came out, which you were major champion for and one of your claim to fame. I'm curious how you think getting into research. I'm curious how you think the research community centers patient outcomes around it, or do you think the research community is driven around alternative incentives? And not to say that there's any malicious intent or anything, but people are really frustrated with the slow pace of cancer research. And we're in cancer research, I get it. I'm curious if you think the priorities are aligned appropriately.
It's easy to get into like whine, moan. But is it the best of all possible worlds unless you can present something else which is possible? I think, as you may or may not know, I spent 18 months actually working in the pharmaceutical industry at AstraZeneca many years ago, and that completely destroyed the sort of them and us attitude. Mm-hmm. What it did create was an understanding that different people in different aspects of healthcare, industry, regulatory, have different metrics for success.
Yeah.
And you can't fight against those. You have to find the common ground. So there's no point proposing a study to a drug company to say, and now I'm going to prove who your drug doesn't work in. That may be important, but they're not going to fund that. Whereas if you propose something that says, I want to see if it will also work in this population, that's also an important question, but they're much more interested in funding that because there's a market associated with it. So you have to find amongst all of the possible questions and all of them which are interesting, which ones are also feasible.
That makes sense from a longitudinal viability perspective, but it also is a testament that it has to be marketable. It has to be profitable. And I think there's a lot of patients that, rare diseases, things like that say that would be misaligned. And I'm not saying that there is a good alternative, but I think, when we can acknowledge where those misalignments are, it's a good step toward, with healthy appreciation of why they're misaligned. I think that's a good step toward progress. And I think the example you gave about pharmaceutical companies is where a lot of people jump to. And I am also on the side that I know a lot of folks in pharma, they're dedicating their lives to curing cancers or treating cancers to the best of their ability. And they have to, the only way they can do that is through the system that they have. So I wouldn't blame the people in those systems to the same degree that I think is perhaps a reasonable impulse for patients who aren't familiar with the system to do. I think it is easy to look at the pharmaceutical industry as a whole and say this is a for-profit industry, and they just care about how long can someone be on this pill, and I don't think that's necessarily true. That being said, they do have to make a certain amount of money to go, to continue to work on things, and if something's high risk, high reward, they may be less likely to pursue that because they can't absorb the risk. So I wonder if the way the research is pushed forward, and this is true in academics too, I've heard a lot of people identify success in academic medicine about number of manuscripts, about the number of grants. And I see, I suppose, less chatter about how likely is this going to translate into a development, or how many patients has this potentially helped. And I say that knowing well who I'm talking to. A lot of the work you've done has revolutionized the field of ALK-driven lung cancer. I think you're someone who can say that the work you've championed has dramatically improved and saved lives. But I don't know if that's, at least early career maybe, that's not a metric I frequently hear about.
I mean, I think that's a really good point. I think, so once upon a time I was a basic scientist. I did a PhD in a basic science lab and a postdoc, and then I came back to clinical medicine. And when you're a basic scientist, you can see this now when you see awards given for basic. They don't say how many papers they've got or how many grants they've got. Maybe they say if they were director of this or that. But what they say is what they discovered. So-and-so discovered this molecule, this pathway, whatever. We go to clinical medicine, and it's like, I've got grants and I've got manuscripts. And I want someone to go, what did you discover?
Yeah.
And I think I can list the things that I think I have contributed. I'm not going to. But in my mind, I have things that I say, yes, I made that contribution. My personal annoyance is when we get awards in clinical medicine, they're often given for people who haven't discovered things, who haven't changed the world. For example, have run an organization. I'm fine with that. But call the award for running an organization. Don't pretend that it makes them brilliant at actually the disease in which they're studying. That's the system you work in.
Well, I think the incentive structures around progression through the research community, from what I've seen, is it's a lot of the grants, it's a lot of getting more papers out. And for me, I think it incentivizes low-risk ventures. You have to be able to show some productivity, some incremental benefit. Maybe that'll help someone, but you have to have the papers out.
Yeah.
And I definitely don't have a solution. But I do say I'm voicing my frustration that I see where patients are coming from when they're going to AACR, the American Association for Cancer Research, their global meeting, or they're going to the ASCO, the American Society of Clinical Oncology meeting, and they're looking at all these posters, and they're saying, okay, this is another tyrosine kinase inhibitor in another pill in the same disease that works the same amount but doesn't have that toxicity.
Yeah.
And they're saying, where's the breakthrough? They see a 1 month benefit of progression-free survival, and they're saying, well, who's working on the big stuff? And I totally understand where those in academics are coming from, that those incremental changes, we'll take them. Like, they are important. And you're not going to lose your whole research funding. You're not going to, you showing that progress allows you to keep doing what you're doing in hopes that you're at a position where you can take higher risks.
But do they take the higher risk? Because the trouble is you get into this situation where, if I have a quote from our colleague Paul Bunn, he told me 20 years ago, he said, the function of the grant is to get the money. And because you have to keep the lights on, you have to keep stuff going. Sure, you say, I'm going to study A, B, and C, but that's just what you have to do to get the money.
Yeah, and I think that there's a whole term called grantsmanship.
Yeah.
About, you can have the greatest idea in the world, and if it's not articulated in the way that I think the academic community is expecting, you're not going to get that grant.
Yeah.
I can, not that I've had the greatest ideas in the world, but I've had many grants not be accepted.
You've had many great ideas. They haven't all been recognized.
Right.
Many great ideas.
History will view me very favorably, I believe. Yeah, I think so.
Exactly.
But I think it's frustrating to patients to see the very incremental change, and people are just doing light jabs and they're not throwing haymakers.
Yeah.
And I get that, and I feel the oncology research structure is built to incentivize low risk, incremental productivity. And I'm bothered by that.
So I have my own podcast. Quick plug, my own podcast is called How This Is Building Me. It's nowhere near as good as Cracking Cancer.
I wasn't going to say
but it's my baby. One of the guys I interviewed yet hasn't gone live is a friend of mine I did a PhD with, and we did PhDs in this laboratory in Cambridge, UK, called the Laboratory of Molecular Biology, which is famous because it's produced a gazillion Nobel Prize winners, including Watson and Crick and Max Perut. And Cesar Milstein and Greg Winter, and the list goes on and on. And I was asking him, why do you think, because he's a basic scientist, and I was asking him, why do you think it's so successful? The question is, could this apply to the problem that you're talking about here? And the key thing is that people didn't have to write grants. There was an amount of money that was given to the center that was renewed every 5 years. They didn't have to write individual things for the supplies in their lab. There was just a store where you went down and you said, my lab is this, and they just gave you what you wanted, from restriction enzymes to a test tube. And it was incredible. And they allowed things that would take 5 years to manifest, not 2 years to manifest, in time for the next grant cycle. So if I wanted to revolutionize cancer research, what I'd really want to do is find somebody who isn't necessarily burnt all their energy producing all these publications, but somehow find a way of spotting the young guns like you and saying, I believe in you. Here's $1 million a year for 3 years. You want to?
Actually, in the beginning, I wasn't sold, but as you continue talking,
do you want to keep? I want to finish it, and then you can apply. Okay, $1 million a year for at least 3 years. So it takes some ramp up time. And if at the end of 3 years' time you totally screw up, you take the money away. That's fine. We do some bad bets. It doesn't happen, but maybe just go do whatever you want. If at the end of 3 years you've done something, here's some more money.
Yeah, well, I think one of the challenges, I just started the lab, and one of the challenges I see is 90% of my laboratory-based time is writing.
Yeah.
It's grants. It's not sitting down, looking at the science. And I've had this interaction with patient advocates who talk to me about, oh, have you looked at this, that, or the other? It was at this conference, and I wasn't at that conference, and I haven't had the time to look through this stuff. So I'm learning from patients. And I think it's a challenging thing for people to wrap their head around, is if you're in the research community, a lot of time, it's like being a politician. You're just trying to get elected for the next time.
That's a great analogy.
You're not doing anything.
Yeah.
I mean, luckily we have staff who are doing a lot of the things, but how much better could it be, or how much more productive, or how much more confident will we be in a risk if we had the time to seriously interrogate it? And the reason we don't is security. The security of, here's the $1 million a year, you can have a few staff members, you can fund your research, and no matter what you find, it ensures you've given the best shot because you have the time, as long as you're independently motivated and all those things. But the system right now is nowhere close to that.
The other thing we could do is introduce the concept of success as measured by a challenge. So let's say you get a panel of cell lines or models in whatever your favorite cancer type is. You say, these are the we get rid of the ones where we know what to do. These are the problem ones. Find something, here's $1 million a year for 3 years. And at the end of that, I want you to either it works in all of these things, or it works in some of them, but you can tell me why it works in them and not in the others.
Yeah.
And then I'll give you another $1 million a year.
Yeah, I think that kind of framework would definitely incentivize progress in a way that right now, I feel like I have to have I have to have the safe bets.
Yeah.
I have to have the safe bets. And if you don't, then you don't produce anything. And it's interesting because every other element of my life, I've believed really strongly that if you set a good foundation and you follow principles, things go well. And I still believe that, and I do that. But I don't see the rewards of that quite yet. So that is a long game that I've experienced. And it's tough to watch people, and this is true, I'm sure for you as well, as you see other colleagues in other areas, they can ramp up their academic success quickly with things that are the jabs. And people have to do that. It's not a negative testament to them, and we want that incremental improvement still. But if you're trying to do some of the more high-risk ventures, it can be really discouraging. And I have scientists who I know, who I look up to, who have done that. They haven't produced anything for years, and then they come out with this big thing, And it's like, wow, you came up with a new therapy. I can think of someone who came up with a new therapy in small cell lung cancer, which is not an easy cancer to come up with a new therapy in.
Yeah.
And they're laboratory based. It took them years. And that could have just as easily not delivered.
Yeah.
Even though it was a great idea and everything, one of the first people I worked with in the laboratory was Dr. Brian Drucker at OHSU.
Yeah.
He came up with imatinib, one of the first tyrosine kinase inhibitors ever, very successful. And I asked him, what was your secret to success? What are the advice you would give to someone who's interested in following your path? And he was like, pursue something and be lucky.
Well, it's true. Well, so one of the key things there is, so there's a children's game in Britain that you play, when you're about 5 or 6 years old, called Pass the Parcel. So there's a gift wrapped in multiple layers of wrapping paper. And there's usually a dad back in the day when they had a record player, and he's like playing the music, and you're passing the parcel around between all the kids, and then he lifts the needle off and the music stops. And then whoever's holding the parcel unwraps it, and their hope is that eventually they get down to the level of the gift. So the key thing about being lucky is you have to know when the music stops.
Yeah. Yeah,
so that you're not passing what you think is nothing onto someone else. You go, I think there's something here.
Yeah, which is hard to do, but again, you need the safety of repeated attempts and that experience learned, which I think a lot of folks don't get these days. But yeah, I think all of this was really to come around and ask if, as a patient, have you been upset at the pace of academic research?
I mean, no, I don't think I'm any more upset than I am as an academic. I mean, I recognize that, there are rules in which you have to work, which includes somebody has to pay for it. And I think our job as an academic, or as academics, is we are in part the generator of ideas, but in part we contribute to the conscience of the research team. So it's far too easy to fall into the trap where pharma has the money, pharma has the drugs, and therefore your role with pharma is to suck up to them and agree with everything they say so that you can get the drugs, so that you can have your name at the front of the paper, so you can stand on the podium at the meeting. That's all fine, but let's not pretend, if you're just a yes man or woman, that somehow this is your trial, this is your discovery. I think you can still show value and be valued by the pharmaceutical industry by telling them the truth. Maybe they're not going to pick you as the person who stands up to sell their drug, but they're still going to talk to you behind the scenes to make sure your drug gets to the right place. And I think that's what academics need to re-own, not with arrogance, but with a certain humility, that their job is to bring truth to the equation.
Well, and back to the framing earlier, is how are these things incentivized? How is the structure built? I think it is built to a certain degree that, how you get on the podium may necessarily be different from, fighting with pharma is not a great way to get on the podium, as far as I could tell in my early career, to pitch their drug, telling them it doesn't work in certain circumstances and all these things.
Well, I mean, it's like family. So you form a relationship first, and then it's easier to tell people the truth. Yeah. You don't go, "Hi, evil pharma, your drug is terrible, and let me tell you why." You say, "Hey, Bob, you're a great person. Really love what you're doing. Let's talk about, whether your baby's ugly or beautiful."
I appreciate your perspective there, and even as someone who would be a recipient of what pharma's doing, I think the appreciation that many people are trying their best. The system is challenging. I think there are a lot of patients that really struggle to see how things aren't moving faster. They see something promising at a poster, a phase 1 presentation. I want that drug.
Yeah.
And it's going to be 3 years, until they have access or something like that. And I feel for them. I also think we're, in a way, letting people down by not having quick enough access for things that are promising, quick enough integration into the clinic for things that are promising. I think the pace, it's walking through mud, and I struggle.
Well, let's talk about a couple of things that if we were running the universe, we would change. The first thing is you can create a clinical trial parallel with the pharmaceutical industry by coming up with an idea and approaching them for money. That's relatively successful. They're much, much more likely to fund that than some grant awarding body because they have, more money. Again, within the rules of it's got to be within their interests. Mm-hmm. But expanding who can be treated with a drug is classically what they might be interested in. All they've had to realize is that as cancer becomes more complex, there are multiple subtypes, that you can't just do this in the backyard of one hospital anymore, that you have to involve multiple sites. And that coordination of multiple sites is $1 million on the budget. So we, through Atomic, Academic Thoracic Oncology Medical Investigators Consortium, and various other ones, have started to, over the last 10 years, have started to change the expectation of what that budget should look like to pharma, and say, look, if you want the answer and you think that answer is important, I just don't want a goodie thrown at me. I want the answer from this trial, and you're going to have to pay more for it. It's still cheaper than if you sponsor it directly, but that, I think, is a step in the right direction. And the other thing we should mention is the government-funded cooperative groups in the USA.
Yeah, please.
Which, honestly, are a total cluster. Somehow, they're still under the misapprehension that they are a nimble drug development organization. And the gap that they should fill is the stuff that isn't terribly exciting, isn't going to be funded by pharma, but which is Pepsi versus Coke. Mm-hmm. There's alternatives out there. Which one is actually better? Or de-escalation of therapy. Mm-hmm. Pharma is never going to say, well, if I give less drug, is it just as good? A cooperative group could. The trouble is the budget is cut and cut and cut, and there's so much red tape and so many other people coming in with their own ideas. It's very like government in another sense, where people are adding things to bills, because it's their pet thing. Somehow, if that could be cleaned up and somebody said, look, guys, you are not coming up with brilliant academic ideas. You need to answer real world questions and strip those down and make them fit for purpose. Because I think they've lost their way.
No, I haven't had a lot of personal experience with them, but the ones that I've seen are 3 years late. The question they're answering was a question relevant years ago. And now, luckily we're in a position where there is some progress, and this new therapy comes and makes the question you're asking potentially irrelevant. But yeah, so I think the delays, the red tape, people feel that.
The other thing is if you look, and by many friends of mine, but when the end point of your study is to show that it's feasible to do the study, yeah, you've kind of lost your way. The end point of the study should be to produce an answer which is relevant, that informs standard of care.
Yeah, and I've had that. I'm still early in my career, but I've had that experience learning to do that for the grantsmanship. We're going to do this feasibility thing because I know if it's not in there, you're not going to accept it. And if I propose it in a way that would answer the question, it's not fundable. It's too much money. So I have to essentially waste this amount on a feasibility study to say I can inject a mouse with this, who has this, like we've done in academic oncology for the last, however many decades.
It's prove that it's feasible to get up in the morning and have breakfast. Okay, now you can actually go to work that day.
Yeah. All right, well, before we wrap up here, if there's one change that you could implement in the clinical care of cancer patients with the new knowledge you've gained from your diagnosis, what would that change be?
I would take administrators in a hospital. I would make them walk in the shoes of a cancer patient for a day. And in the midst of putting them in a gown and funny-looking paper shorts to get their scan, I would deliberately delay their scan by about an hour. Then just go, oops, sorry. Because that's what happens.
Do you think that would solve anything, or do you think it would just be fun to do? Either way is fine.
Is it just like payback?
Yeah.
No, I think... So the classic example I actually have in my mind isn't about delays on scans. It's about the fact that they'll stick a drip in your arm to give you the contrast for a scan, And then you'll say, can you take my blood sample through here? And they go, no, that has to go on somewhere else. And they pull the drip out and send you somewhere else to get a second needle stick so that both places can bill.
Yeah.
I want to do that to the CEO of the hospital.
We'll figure out a way to make that happen. No, it gets to the same thing of the invisible walls, the invisible barriers that to a logical person shouldn't exist.
Yeah.
And we're not in the most logical of systems. Well, hey, thanks so much for coming to join. Hopefully you enjoyed coming on and having the discussion around this very relevant topic.
I've been curious to see what it was like. It's a cool podcast.
It's like this. Yeah, it's pretty similar to this. Well, thanks so much. And everyone, thanks for listening. This has been Cracking Cancer, and you can go to crackingcancer.org for more information and like and subscribe to hear more of this. And hopefully we have additional conversations in the future. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.